is. Good. So, well, let me talk a little bit about hypothermia today, and I would like to discuss with you, well, possible, or let's say possible and proven indications for hypothermia. And when I start with that, you should know that hypothermia, let me see, is a real old issue. It has been studied really in the times of the old Greeks, and we have literature that Hippocrates started thinking of hypothermia, treating patients with ice and snow to reduce blood loss. So it's really something which I would say has a long-lasting tradition, but it took a while for medicine to pick up it again. You know that during the war with Russia, the Napoleon field doctor described for the first time that warming the patient could be detrimental, and when he found that the soldiers who were wounded and were near the campfire died faster than those who had no rewarming. So that was something which was followed then for well, ages, and hypothermia was in the 50s or in the 40s the only way to do open heart surgery, because you didn't have any form of neuroprotection. Obviously, we didn't have at that time heart-lung machines. So what you see here, for instance, is one of these examples where the patient was really soaked like a, well, I would say like a frozen margarita or something here in the ice cube bed. And you can imagine that this was really cutting edge operations at that time. So it was very, very difficult to cool the patient, and the side effects were enormous. So fortunately enough, things developed further. But all of you are aware of these stories which run through the newspapers everywhere around the world. This like the child was drowned somewhere in the sea, and even after 60 minutes or more downtime, they recover completely. And so everybody thinks there is something good about temperature and reducing body temperature, but it was not clear for, well, mid of the 80s, I would say, in the last century, how we can use hypothermia in a more fancy way, I would say, not like what I've shown you before. And at that time, it came up that you know, the pathways of ischemia were so difficult. As you know, we did a lot of studies about different, about starting up with the GABA antagonists and the calcium antagonists, and as you know, all of those were negative. And when you see this pretty simplified scheme here, you can imagine that the downside of this cytotoxic cascade is, well, not controllable with a single substance. So that's the reason why hypothermia is so effective and attractive for us, because it works more or less on every and each single pathway, which makes it well, more or less a dirty drug, which works, as I said, on all pathways which you can think of. So everything in our body is temperature dependent. With a lower body temperature, things go slower. And that's the idea, more or less, just to simplify that, that hypothermia could be some possible target in neuroprotection. And what we know is from, well, thousands of animal models that reducing body temperature in any kind of neuronal injuries is beneficial. We know, and you have David Greer here next week, so he did some publishing papers about that. We know that there's an association between fever and clinical outcome. And of course, we have the level 1 evidence for cardiac arrest as well as for perinatal asphyxia. So Let me start with the first indication. And of course, you know that the first and really firm indication is cardiac arrest. And that was done now almost 15 years ago when the group from Fritz Sterz in Wien and others started up doing hypothermia for patients with out-of-hospital cardiac arrest, ventricular fibrillation patients, and they started cooling them. And at that time, it was a real difficult maneuver. You see here, that was more or less the prototype sort of bed at that time where the patient was put in. It was more or less like a tent. So it was difficult for everybody to come close to the patient. For the nurse, it was almost impossible to reach the patient. But it was the only way to achieve cooling in a reasonable time window. And when I talk about reasonable, it took almost 6 to 7 hours after the cardiac arrest to cool the patient to the goal temperature of 33 degrees. And it could take a lot longer. So it was not very sufficient what we had at that time. Nevertheless, these were the first papers published on patients with cardiac arrest who did show an effect of the intervention. And as you know, the intervention did increase the probability of good clinical outcome with a net of almost 10 or more % depending on the studies. So it was really a major breakthrough in the management of patients with cardiac arrest. And after that, almost everybody was at least interested in hypothermia. And we discussed yesterday of how many really instituted the protocols, and that was a gradually increase over the upcoming years that more and more critical care centers used hypothermia for patients with at least ventricular fibrillation and cardiac arrest. And nowadays, we do that also in non-shockable rhythms or patients with electrical silence. And as I said, the net benefit is enormous. And the net benefit is really something where you could argue, why don't we do it really everywhere around the world, since these studies were done 15 years ago. So it is really something where all resuscitation boards around the world say this is level 1 evidence, you have to do it for a patient with a cardiac arrest. And after this, we had a numerous, well, not randomized, but open label studies, Mauro Otto and others, who all used more or less the same regimen of 24-hour cooling and 24-hour cooling compared with standard normothermic therapy. And the results were pretty similar in all these trials. Everywhere, hypothermia did better. And at that time, more and more centers used it not only in those patients with ventricular fibrillation, but also in asystole patients. So it was really something, and the results are comparable everywhere. It's a net 10% difference between hypothermia and normothermia in all these studies. And I can go over that. What I would like to show you now is the guidelines, and the guidelines are pretty clear. So unconscious patient with spontaneous circulation after out-of-hospital cardiac arrest should be cooled for 12 to 24 hours, and it seems to be reasonable for other causes of cardiac arrest, initial rhythms, and that was 2010. So when we think of, well, how can we further improve the care for those patients? One could think of, we have this induction phase where we probably all would agree that this should work as fast as possible. I told you in the initial trial from Vienna, it took almost 6 hours to reach target temperature, and it could be longer. So it makes sense to do a rapid cooling and perhaps reach the target of 33 degrees within an hour or 2 hours if possible. Then you need to have a maintenance phase which needs to be pretty stable. So it does not make sense if you go up and down with the temperature. That can cause obviously side effects. And there's the critical phase of rewarming, where we all nowadays agree that this should be as slow as possible. And the guidelines say 0.2 to 0.5 degrees per hour. So that is something which really requires a technique which allows you to do this slow rewarming. So you cannot do it with ice bags. So we need something more sophisticated here. So the cooling procedure, as I said, it's more or less 4 parts. It's the induction of hypothermia, and as you know, more and more centers use even in the field inducing hypothermia. So we have the emergency physicians, for instance, which use the infusion of ice-cold saline. You can have ice-cold or ice cube bags, which you pour over the patient. You have the nasopharyngeal cooling, which I'll show you later on, which could be something on the site to reduce the body temperature. In the hospital, obviously, we have either surface cooling or endovascular cooling for maintenance and rewarming. And I would like to stress that you have to have a protocol even after the hypothermia. So it doesn't make sense to stop hypothermia and then the patient peaks with the fever and you don't take care of that. So you have to have a temperature management even after the cardiac arrest. So there are different options for that. But if you think of how you really institute such a protocol, it's pretty clear that you have to think of whom should I cool. It's clear that those patients who recover and regain consciousness after the cardiac arrest, it does not make sense to cool them. But if these patients are comatose, then you should start immediate cooling and treat them as early as possible. And of course, you have to treat the causes of the arrest, which is in most instances something for the revascularization. And of course, other things like glucose control and. And something which I would really like to stress here is don't reduce the therapy too early. So the regular site is normally 24, 48 hours, and for neurological prognostication, which is even major thing, is it's the rule nowadays that you wait at least 72 hours before you do a neurological prognostication on the patient after the cardiac arrest. So that would be an easy story and pretty straightforward. And of course, you have seen last year, or it was actually in December 2013, the TTM trial. That was the Swedish trial on targeted temperature management, where they compared patients with cardiac arrest, bystander, more or less to say bystander cardiac arrest, and randomization between 33 and 36 degrees temperature. And to make it short, there was no difference between the two temperature regimens. And that brought an obvious discussion of how we should interpret these results. And if we have to take a little closer look at the trial to interpret the results in a way that we can go forward. So the most important thing is that almost 90% of the patients which were treated here in this trial were bystander cardiac arrest patients. So that means the patient had the cardiac arrest and there were anybody around this patient who saw and witnessed the time of onset and started immediate life support. And that is something which is really an extraordinary, brilliant, I must say, way how things work in the Scandinavian countries, especially in Sweden, where you know that the bystander cardiac arrest is trained in the grammar schools. So really the young kids with 6, 7 years learn how or what they should do in a patient with a cardiac arrest. And therefore it is much more professional and much more effective than in any other country I'm aware of. So that is something which you have to keep in mind. So it's in this trial, the vast majority of patients was treated early on, and here you see the two groups, the 33 and the 36 degree group. And what you should also notice is that even the 36 degree group had a real tight control of temperature. So it's not saying we didn't do nothing with those patients. No, it's a tight temperature control for those patients in the trial. So it's not hypothermia against nothing. It's again hypothermia against smaller degrees of hypothermia, so to say. In terms of the side effects, there was no difference between the two temperature regimens, but what you should even, well, I mentioned that, but here you see it again, the question of the outcome of patients with a short downtime. That means those with the witness bystander arrest. And what you see here, and you see replicate that in many other trials, is that those patients who have a short downtime, like 10 minutes or less, they have a good outcome in most of the cases. So it doesn't really matter whether these are shockable or non-shockable arrhythms, they usually have a relatively good outcome. That differs the longer the downtime is. So that means when you have a downtime of more than 30 minutes, things get a lot worse. For those who have no shockable rhythms and have a downtime of more than 30 minutes, the majority of those will not recover consciousness and will die. So in the TTM trial, they really concentrated on this group. So that means, well, we have no significant difference in this trial between hypothermia and targeted temperature management. That's the reason why, because they have overall a low mortality and relatively good outcome. So most of us would agree that these were probably less severe injured patients than in these trials which I mentioned you before. So the bottom line here is you can make a local decision of how to cool the patient. It may well be that you can use a target temperature of 36 degrees in certain instances, but please, and that's the conclusion, keep on cooling, because we have no evidence that no cooling could do benefit. So keep on cooling, and well, we can discuss that later on, but I would say the 33 degrees are still considered to be the gold standard for these patients. So let me come to the next set of diseases where we could think of hypothermia, and that is, of course, traumatic brain injury. And you are aware that there have been numerous studies, and the first one was the Guy Clifton trial, which was on a larger scale, and the editorial in the New England Journal said, well, it's a good idea, but it proved ineffective. So why was that so? This it was really a very difficult trial at this time, and I think Guy Clifton knows that he really has lost a chance here. And the reason was that the treatment protocol, or the peri-procedural protocol, was not well defined at all. At least it was more or less not defined. That means it was clear that you should start cooling as early as possible, but it well could be that those patients who were randomized to one or the other group, let's assume they were randomized to normothermia and were spontaneous hypothermics, they were actively rewarmed and vice versa. So it was a little bit of a mess. And more important, the management of elevated ICP was so different between the centers. I mentioned that at that time the colleagues in Birmingham, for instance, which had a 15% net negative outcome with hypothermia, compared to Houston, where they had a 15% net positive outcome for hypothermia. You may ask, what's the difference between Birmingham, Alabama, and Houston? And the reason was, for instance, in Birmingham, they used permissive hypotonia for the management of elevated ICP. So they just let the blood pressure drop. And all of you would agree that nowadays nobody would do that. So it is something which explains at least some of the enormous differences in outcome in these trials. So that was really the problem. These are the results. Hypothermia did worse than normothermia, and I mentioned to you it was a lot of things which could have been done better, especially in the treatment protocol. But things went on, and more people analyzed all the head trauma trials, and they came more or less all to the same conclusion, that the studies were often inadequate in the treatment protocols, and therefore one cannot say whether hypothermia is indicated or not in head trauma. We had then meta-analysis. Here's one from 2010, which nicely shows that you should treat earlier, you should treat those patients with elevated ICP, and Keith Poleman published an analysis of all the trials which were available at that time, and what you see is that in all of those, the reduction of elevated ICP was possible, with the big exception of the Clifton trial. So the question is, how do we go on? You know that Guy Clifton was able to have funding for a second trial, NABISH trial, which had the problem, what you see here, that the numbers were really, really small. At the bottom line, it was a comparison of 50 patients in each group. And the results were, well, more or less nothing to say about it. So it was no difference between normothermia and hypothermia. There might have been, or there may have been a subgroup for those with a surgical removed hematoma, where hypothermia compared to normothermia may have had anything to it, but otherwise I must say the trial is much too small to really give you any evidence in the management of head trauma patients. But we have another one just knocking at the door. That's the European Eurotherm trial. Peter Andrews is running this one, and I can tell you it will be published this year. And this is something which is very well defined. It has a hypothermia as an intervention for elevated ICP in patients with head trauma, with a clear protocol, with a stepwise strategy. And just to let you know what it is, it starts with the basic support, CSF drainage, and then you have hypertonic saline, mannitol, and barbiturates as only third stage. And here ICP or hypothermia is part of the intervention, and the outcome measures are clinical outcome as well as ICP control. And we have the first, preliminary data about ICP control. And what you see here is that it, as all the studies showed before, it can reduce ICP. The question is whether that translates into clinical outcome. And that's the big question which we are all looking forward to see. But at the moment, I think I would be pretty sure that it will show an effect of this management for patients with head trauma. Up to now, we have only, as I said, meta-analysis available, and what they all show is that hypothermia and head trauma, when used appropriate in patients with elevated ICP, can reduce mortality, it can improve outcome, and may have some signs in terms of side effects, especially pneumonia rate is a little bit higher than in the control groups. But all of these meta-analyses have the bottom line: there needs to be more high-quality studies in patients with traumatic brain injury. And that is something which is really true when you compare traumatic brain injury with ischemic stroke, for instance, or other diseases, that the quality of the, well, let's say, data and management, peri-procedural management, is relatively vague when you see what is done, for instance, in stroke care. But nevertheless, I think up to now, prophylactic hypothermia is nothing which you should do in head trauma. It's at the moment only for those patients where you try to reach ICP control and have no other therapies available. You should do the therapy longer than 48 hours, and the 33 degrees are here the most well, appropriate ones, I would say, even though it has not been studied with 36 degrees, for instance. And again, here comes the point of the slow rewarming. Similar to ischemic stroke and cardiac arrest, slow rewarming is something which all of these studies advocate. Okay, so we have cardiac arrest, we have head trauma. Now we come to ischemic stroke. In ischemic stroke, the evidence in experimental models is the largest we have available. So since 1985, where Raoul Busto published the first papers on mild hypothermia in ischemic stroke in animals, we have more than, well, 3,000-4,000 hits when you look at the Medline. So summing up here is, the earlier you do hypothermia, the better it is. The longer you do it, the better it is. Delayed treatment requires prolonged cooling. It's more effective in transient ischemia than in permanent ischemia, though that means in reperfusion models, it's better than in permanent occlusion. It can be combined with thrombolytic therapy, but duration and depth of hypothermia are still uncertain. So usually we sort of do the analysis similar to the studies in cardiac arrest. Well, when we translate that into the clinical scenario, it's, as I said, earlier is better. So the question is, how can we reach early on hypothermia in the cardiac arrest? It's, as I said, it should be something which is available on site, like nasopharyngeal cooling, ice-cold saline infusion, things which you can do also in ischemic stroke patients. I will show you later on some data on that. Then the duration plays a role. Here you see that the longer you do it and the depth of the hypothermia are something which, well, we would agree that the bus temperature here is between 34 and 33 degrees Celsius in the animal model. And you have to think of the contrary, the fever management. So that was on hypothermia, but first step is always manage fever. And what you know is that fever is something which is detrimental for your individual stroke patient, and that is from our group at that time in Heidelberg, where we measured brain temperature in stroke patients. And we regularly saw that the brain temperature was more or less 1 degree higher than the body temperature. So a further argument for aggressive reducing body temperature in patients with an ischemic stroke. Michael Duringer published the analysis from his database, and again you see that for all diseases like intracranial hemorrhages, cerebral ischemia, subarachnoid hemorrhages, when you have fever on board, outcome is much worse than with those patients who have no fever. So it absolutely makes sense, first of all, to treat fever, not to talk about hypothermia, but to treat fever. And the fever management is really something which is of utmost importance here on the stroke unit as well as on the neurocritical care unit. Here, that is from our friend Greer. He published this 2008, and that was an analysis of all the data we were available at that time. And what you see here, that is that almost all studies show that normothermia is favorable for patients with ischemic stroke. So how can you achieve that? Obviously, there are different ways to control fever, but what is clear that is the uncontrolled fever management is something which is really difficult and is for the nurses demanding, and therefore you need to have a decent strategy for that. And I can show you here, this is our treatment protocol in our stroke unit in Erlangen, where we have a stepwise escalation for patients with fever, where we start probably similar to all of you with paracetamol and metamizole. Then we do ice cold wrappings, and if that is not effective, we infuse ice cold saline just to reduce the body temperature. And we allow us overall not more than 4 to 6 hours to really achieve normothermia. And I think that is important when you look at the burden of fever, when you compare this regimen with these more or less standard-wise regimen where you say, well, I look 4 hours later about the temperature and then I decide what to do. And you see clearly that this is much more effective in reducing fever burden than a standard protocol. So I would say, first of all, and that is pretty clear from what we have, is that sufficient fever management is beneficial for the patient. But that is nothing about hypothermia. And you may ask now, what do we have as evidence for hypothermia in stroke patients? And I'm sure you are aware that there is or there are many centers which use hypothermia for stroke in the ICU. And just as an example, you see here, it's a lot of machines around the patient at that time, and you see here the surface cooling devices or anything which allows you to reduce the body temperature. And we did that initially in the very severe stroke patients. And we saw something which was very similar to traumatic brain injury. We can reduce elevated ICP in those patients, and that is pretty effective. And that at that time was a regimen which could be used as an alternative, for instance, for decompressive surgery in the very severe affected malignant MCA infarcts. What we saw, and I think that is the only study which addressed this topic, when we rewarmed the patient, we had a subgroup of patients here. At that time, we did only passive rewarming. So that means we stopped cooling and allowed the passive rewarming of the patient. And there was a subgroup of patients who really showed an overshoot elevation of ICP and finally died. And that brought us to the concept of active rewarming with endovascular devices like 0.1 to 0.2 degrees per hour to overcome this problem. But for stroke patients, the question is not on the ICU, intubation and ventilation. Obviously, we want to have that in awake patients. And that's the big difference to traumatic brain injury and cardiac arrest. You don't have intubated patients here on the stroke unit, and it's a lot more difficult to do hypothermia in awake patients than it is in intubated patients. Nevertheless, we have studies now which do that, and one of the larger ones, even though the numbers are small, is the ICTUS trial here from Pat Lydon and Thomas Hammond. And what you see here is they did use it, and you may ask about the side effects. At that time, pneumonia rate was the only severe side effect, and when they did look for the reason, it was pretty simple. They had a regimen where they first gave the petidin, and after that they inserted a nasogastric tube. So you can think of, well, that is not a good idea because you induce nausea, and with then placing the nasogastric tube, you further induce vomiting, and obviously that was one of the reasons why those initial patients had more pneumonias. Now in the larger trial, they don't have more pneumonias, and I can tell you even in our trial, there's not an increased pneumonia rate. Katja Pyronen from Markus Kastes group in Finland, Helsinki, had also a pilot study, small pilot study with surface cooling in stroke patients. And you see it's demanding procedure, but it can be done with an anti-shivering protocol, which we will discuss later on. And she observed some side effects, but it was not that difficult to induce hypothermia. And the conclusion here was it's safe and feasible, and we should go on with that. And as I told you, the large trials are missing at the moment, and we have now two large trials. One is our European trial, and the other one is the ICTUS 2-3 trial in the US. And when I be back in Germany, we have the results of the first 100 patients here available for ICTUS in a telephone conference. They are more or less companion trials and use a similar protocol, and hopefully we will have more available on this in the next few months. But up to now, the essential elements for awake patients treated with hypothermia is you have to have a fast induction of temperature. You need something which effectively decreases temperature. Of course, it's a question of tolerability and feasibility, and you have to think of the benefit who may outweigh side effects. And that brings me to the point of what do we use to institute hypothermia. You can have preclinical approaches, you can have in-hospital approaches, and the pre-hospital cooling is something which is really attractive, especially for the cardiac arrest patients. And you see here there's a variety of things available, like these pretty simple things like these ice cubes which are placed on the patient. Here you have the nasopharyngeal cooling devices, you have cooling helmets, cooling vests. All of this is available and may help to initially decrease temperature. In the hospital, there are principally two options: surface cooling pads, which in my eyes are a bit difficult, and I can tell you our nurses don't like that at all because they cannot approach the patient, and it's a lot of hassle about the patient. They love the endovascular devices, which are the most powerful ones. So they allow you to reduce body temperature pretty aggressively and effectively, and allow you really guiding the therapy, maintenance and rewarming much better than any other devices at the moment. And that is nowadays well, I would say number one and gold standard for that. That's the Sol device with these catheters, which you can use also for infusion. So it's not only a cooling catheter, but it's also a central line for the patient, and that allows you to reduce body temperature quite effectively. You have seen this one before, and that is just to show you that you have to have ideas when you do well, resuscitation in this case. This was a patient who had a cardiac arrest in the supermarket, and the anesthesiologist on site was pretty smart, and he used ice cold frozen French fries to cool the patient. And that was really effective, and the patient is well off. He's still active, and I think that is the simple way how you can reduce body temperature. And nowadays we wouldn't use this, but obviously more and more centers use like the nasopharyngeal cooling or infusion of ice cold saline, as we do in our center for stroke patients, for instance. Here you see an example of how we reduce body temperature prior to imaging to reduce the temperature, as I said here, up to 1.5 degrees just by the infusion of ice cold saline. One could think of other modes to achieve hypothermia, and obviously that would be very attractive, but at the moment I must say there's nothing out there which really allows you an infusion to hibernate the patient. I mean, that would be obviously something for the future, and all of us are thinking of such substances, and I think the most promising one was this study here on dihydrocapsaicin, the chili, which is a substance which allows in a dose-wise manner to reduce body temperature. But you may ask, well, why don't you use it? It had, in animal models, at least there were side effects described, especially in models with cerebral ischemia. So there's nobody who is patenting this substance, so I doubt that it may be something for the future. But everybody looks for such devices or such substances. So just to sum up here is, I think I have shown you that hypothermia has a large body of evidence that it's neuroprotective, especially for cardiac arrest, for traumatic brain injury, especially for those patients with elevated ICP, and for stroke it needs to be determined. But it's effective when you administer it fast and for a longer period. Even short shots of hypothermia might be beneficial, and I can tell you we are working now on an endovascular catheter which is instituted with the thrombectomy and should flush the brain just for 30 minutes with ice cold saline during the procedure, which may be another option to reduce reperfusion injury in thrombectomies. 35 degrees on the stroke unit is more practical than lower temperatures. Side effects can be sufficiently controlled. We all had initially the fear that we may cause coagulopathies, we may cause arrhythmias, we may cause infections, and I can tell you none of this is really an issue. The only thing might be pneumonia rate, but even that is manageable. Lower temperatures are helpful in cases of patients with ICP increase, and that is true for stroke as well as for traumatic brain injury. And with that, I would like to thank you for this first talk, and I'm happy to have your questions.